Welcome to Medication Talk, the official podcast of TRC Healthcare, home of pharmacist letter, prescriber insights, RX Advanced, and the most trusted clinical resources. On today's episode, we'll listen in as our expert panel discusses the latest recommendations for COVID-19 and influenza vaccinations, and options to prevent respiratory syncytial virus, RSV. Additionally, our panel will discuss practical approaches for giving multiple vaccines in a single visit. Our guest today is Dr. Shana Castillo from Creighton University. You'll also hear practical advice from panelists on TRC's Editorial Advisory Board, Dr. Reid Blackwelder from East Tennessee State University, Dr. Stephen Carek from the USC School of Medicine, Greenville, and Dr. Craig Williams from the Oregon Health and Science University. This podcast is an extract from TRC's Emerging Recommendations panel webinar. Each month, experts and frontline providers discuss current medication therapy topics and practical recommendations to include in TRC's letter articles. The full webinar originally aired on October 16, 2023.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, physicians, and nurses. Please log into your pharmacist letter or prescriber insights account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Now, let's join TRC editor Dr. Sarah Clockers and start our discussion.
So we're all gearing up this fall and winter with lots of vaccines. They're in full swing for the triad of respiratory illnesses this fall and winter. So let's review the recommendations starting with COVID-19. In our October issue, we wrote about the updated mRNA COVID vaccines, and we now have the Novavax that's approved. So Shana, could you briefly review the updated recommendations for the monovalent updated COVID-19 vaccines that cover the Omicron XBB 1.5 variant?
Sure. Thank you, Sarah. Happy to be here. So really, the recommendation we're going to see for COVID is really kind of similar in a way to the flu vaccine recommendation in that it's going to be for everyone 6 months and older. And so really, the recommendation is for everyone to get that vaccine. Now, we've got the Pfizer vaccine and we've got the Moderna vaccine, which we know can be dosed all the way down to 6 months. The Novavax, which was just recently approved, is really only for people 12 years of age and older. But really, if it's a vaccinated adult, they're just going to get one dose of this updated vaccine unless they're an immunocompromised patient.
I think we'd like to spend just a couple of minutes just reviewing those updated vaccine options. Stephen, would you mind just kind of giving us an overview of the two different types?
Yeah, I mean, as far as my understanding is two main vaccine types now, the mRNA and the protein-based vaccine. We're all familiar with the mRNA vaccines that we've been utilizing over the past few years since vaccines first became available for COVID, most commonly being the Moderna and the Pfizer versions. And now, at least in the past year, utilizing the protein vaccine or the Novavax, the adjuvant vaccine that we have been given out these past, 12 months now.
Excellent. Thank you. And as you mentioned, Shana, the different types are for different age groups. They also have different recommendations for use. And so would you mind reviewing when we would recommend which one? Because I do think it is a little confusing. Initially with the mRNA, it was just one updated dose for everyone 5 and older. But now with the Novavax in the picture, it's a little different.
Yeah, so I should have said that when I mentioned the Novavax earlier, but so 6 months to 4 years, they're going to get multiple doses depending on their age, their prior vaccination, and at least one of those is going to be a dose of the updated vaccine. And so for 6 months to 4 years, if you're going to give a Moderna or a Pfizer, and you're either going to give 2 doses of the Moderna or 3 doses of the Pfizer if they're unvaccinated. If they are vaccinated, it changes a little bit based on what they've had. So 5 years and older, if you're using Pfizer or Moderna, you're going to give 1 dose of the updated vaccine. 12 years and older, you're going to give 1 dose of the updated vaccine if it's a Pfizer or Moderna. If it is the Novavax, it depends on if they've been vaccinated or not. So if they have had a prior COVID vaccination, you would give 1 dose. No prior COVID vaccination, you would give 2 doses. And then immunocompromised gets a little bit trickier. And so that, again, depends on prior vaccination, but you're going to give at least 1 dose of the updated vaccine and then possibly more doses as well. And with the Novavax, you're going to consider additional doses as well. So the immunocompromised, I think, gets a little bit trickier, and that's where I maybe would look things up if I had a chance to, because it's a little bit more complicated. I think really 5 years of age and older with no immunocompromisation is the easiest one to remember, because you can just do 1 dose of an mRNA or 2 doses of Novavax if they haven't had any vaccination. It's a little trickier in that younger age group and the immunocompromised population.
I know we've had some questions about differences. So I think the question that everybody wants to know is, would you consider using the mRNA vaccine over the Novavax? Or I've actually seen some people say that they want to track down the Novavax based on some information that they've seen on side effects. Can you comment on that?
I don't think we have enough information to say one is necessarily better than, I would say, I think mRNA has kind of been the gold standard from the get-go, but I would say if someone only has Novavax available, go with Novavax. I think getting vaccinated would be more important than waiting for a certain vaccine. So that I guess that would be my comment.
We still do encounter some hesitancy. The whole mRNA vaccine thing still is kind of out there in different pockets. And so it's nice to have an option for people that just, for whatever reason, have an opposition to the technology or what they've read about the mRNA vaccines.
This is Reid. I mean, I agree. I'm still hearing that as well. And while vaccination shouldn't have a political connotation, there's no question there is with the misinformation. And it can be very tough to overcome that. So it is kind of nice to have an option that, from a patient perspective, is more like what they're used to, and they don't have to worry about the new technology, for which there's unfortunately a great deal of suspicion.
So let's jump in and move on to influenza so we can get to some questions at the end. And we wrote about this in our September issue. Shana, can you just briefly review the main changes for this year's flu vaccine?
Yeah, there are really only 2 main changes in the recommendations this year. They updated the composition, as is always kind of one of the major changes every year. And then the second major change was that guidance for people with egg allergies. So it used to be that if someone had a very severe egg allergy, we wanted to only vaccinate them in a medical facility where there was experience managing severe allergic reactions. They've done enough studies now, they've got enough data to determine that really the risk of anaphylactic reaction in someone with egg allergy isn't any different than the risk with anyone else. And so the new recommendation is that anyone with an egg allergy can get any vaccine, and it can be in any setting, and the precautions that should be taken are the same as the precautions that should be taken for anyone getting a flu vaccine. We do still have the egg-free, so the cell-cultured vaccine and then the recombinant vaccine are still available, and those are both egg-free. So if someone really doesn't want to get a vaccine that has some egg in it, then they could get those.
Awesome, thank you. And as you said earlier, the recommendation in general sounds very similar to the COVID recommendation, in that we would recommend any age-appropriate vaccine for everyone 6 months and older. So that's helpful that they're similar. But I do think we want to review, there are some nuances with the different products. So could you just briefly, you mentioned the 2 egg-free options, but can you briefly review what other patients might need a different, or you would recommend a different vaccine for?
Yeah, so for patients over 65, the recommendation is for them to get 65 and older, I should say. The recommendation is for them to get that high dose vaccine or the adjuvanted vaccine or the recombinant vaccine. So the reasoning there is that because those have either a higher amount of antigen or they have that adjuvant, it just boosts those patients' immune system a little bit more. And since they're high risk at that age, we want to try to do that. Oh, and then the other thing is that we want to just remember that that live attenuated intranasal vaccine is really only for healthy people, non-pregnant people, and the ages for that one are 2 through 49. So it's really much narrower group of patients that can get that one.
Yes, and I think we get a lot of questions too about vaccinating in pregnancy. So could you just comment on that? I think there are just questions on, we say here not to use the live attenuated vaccine.
Yes, but they definitely should be getting an inactivated vaccine. Pregnant women are at very high risk for influenza complications, and so we want to make sure that we are definitely vaccinating them with an inactivated vaccine. And any trimester, you know, sometimes people are hesitant to get vaccines that first trimester, but this is one that should be given anytime during pregnancy.
I think too, Sarah, we've always used the selling point of some passive immunity for your child. So regardless of their personal history, we sell a little bit to protect your child that may be born right into a bad flu season in several months.
Let's go ahead and move on to RSV vaccines so we have time to get to some of the Q&A. We wrote about the RSV vaccines in older adults in September. We've had some changes and updates to this vaccine as well. So let's just start off with a quick overview of the available vaccines, and then we'll go on to who we would recommend them for. Would you mind reviewing that, Shana?
Yeah, so we have 2 vaccines here now, the Abrysvo and the Arexvy. And the Arexvy is the one that is the adjuvanted, the Abrysvo is not. They are both approved for adults 60 years of age and older. Arexvy was originally approved, and then the Abrysvo was approved. And then they also got the approval for pregnant patients between 32 and 36 weeks gestation.
Excellent, thank you. And Reid, I wanted to ask you, how do you discuss with your patients whether or not to get the RSV vaccine, especially since it's really too soon to say how well either of these prevent hospitalizations in older adults?
That's a great question. So I'm frustrated this country is one of 2 in the world that has direct-to-consumer advertising. But I will say for RSV, the ads are certainly out there heavily promoting the vaccine, and it gives a good opportunity to talk about it. And I usually point out that we did suffer through the tridemic, the influenza, COVID, and RSV. And I basically share that, you know, my experience has been that while this has generally been a pediatric illness and certainly the population we were most worried about, we're now seeing very unusual behaviors and more, I guess, probably ability to pick it up better in adults, and that it is not just a cold, that it actually is a fairly serious infection. So I think by bringing up that things are different now than they used to be, and they may or may not truly be that different, but I think the impression is, and because RSV hasn't been quite as politically charged as COVID, it seems to be something that kind of dovetails into the discussion about pneumovax and some of the other protections. So I have not found a lot of resistance to that discussion. That doesn't mean people will get the vaccination, but at least they're open to talking about it in the context of protection.
We also have the bivalent adjuvant-free vaccine Abruzvo for pregnant folks that Shana had mentioned. And we've gotten a lot of questions about the role of this, since we also have the monoclonal antibodies that we can give to the infants. So can you, Shana, comment on when pregnant patients should get the RSV vaccine and how effective it is?
Yeah, so really we're working on those maternal antibodies that are being passed on to the child, right? And so we're going to try to give this between 32 to 36 weeks of pregnancy. So September to January is when we're going to give this to pregnant women to try to protect those babies. And you know, there is another agent that I think we're going to talk about that we would actually give to the babies, but I think this would be our first choice if we can give this to the mom while they're pregnant. This would be our first step in protecting that baby.
Yes, and I think it's a little tricky this year since these are just now coming out and we're headed into RSV season. So yes, we are going to talk briefly about the monoclonal antibodies. We have palivizumab and then the new nirsevimab, which are both given via IM injection in the office. And so these provide immunity a little bit quicker than vaccines, where you're kind of relying on the mom to kind of produce that immunity. And we did write about nirsevimab in our October letter. So this month we're kind of working on the FAQs with these two agents. And I wanted to just kind of briefly review a few of these snippets of information from our article to get everyone's thoughts. So with both of these options and no head-to-head data, we just discussed that, you know, we'd really encourage giving the vaccine. But if you had, you know, access to both options, how do we help parents decide what to do?
With the patient in front of you and talking with the parent, it's, at least from our perspective, do what we can do now and always be in favor of vaccination and sometimes even counseling against some of the potential side effects of the monoclonal antibodies, and that there can be some hypersensitivity reactions that may not be easily predictable. And so far as I understand, the vaccine's fairly safe. And as you said, we can start protecting the infant in the womb. That'd be a great place to start.
Yeah, I 100% agree with that. If we can start there, I think that would be my argument to do that. But there are some women who are just very, very hesitant about getting vaccinated when they're pregnant. And so that might be something that you come up against. But I do think that if we can vaccinate the mom, that's our best option.
Great. Thank you for that. And I think another big question that we are currently getting, and we've gotten a lot since the RSV vaccine and nirsevimab are both available, is would we ever vaccinate the mom and give the infant nirsevimab?
There are very rare situations where if the baby is born, if we vaccinated the mom and they have the baby less than 2 weeks after the vaccination, then we would go ahead and give the monoclonal antibody. Or if there's some reason why we think that the immune response isn't going to be effective, or if the mom got the RSV vaccine and it wasn't in season. So those would be the rare occasions when we would do that.
So let's go ahead and jump over to the vaccine FAQ section of the presentation. And we're going to actually dive in and answer some questions we've been getting over the last month, and then review some of the wording that will be in our November draft, our article, and then we'll answer some of the audience questions if we have time at the end. So I think the number one question, and actually the first question that we got from folks this evening, and I think it's because there's just been some conflicting messages out there from experts along the way with these new vaccines being approved, but can patients get COVID, flu, and RSV vaccines at the same time? So Shana, would you take a stab at answering that question?
Yes, absolutely. In fact, I told my 75-year-old parents to go get all three at one time, because there's really no reason not to. I know that there's been some controversy out there, and there's been some discussion about, do you produce as many antibodies if they're given at the same time? But there's been really no reason to say that clinically it's any different to get them separately as to get them at the same time. The only thing, and I think I don't know if this is a question that might be coming up, but the only thing that might come into consideration is that if you're giving the adjuvanted RSV vaccine and you want to give an adjuvanted flu vaccine, they say you can consider giving a non-adjuvanted flu vaccine, because there's just not data on giving multiple adjuvanted vaccines at the same visit. But they also offer the caveat of, but if that's what you have, give it. There's no data to say we can't give it either. They just say that that's a consideration that you can take. There's no max number of vaccines that we can give at one time. I think adults maybe are a little bit more concerned about getting multiple vaccines at one time when we're so used to doing it in children, right? Children get multiple vaccines at one time, and usually we don't blink an eye. We just, I think, have to kind of consider that and think to ourselves, there's really no max of vaccines that we can get, and there's no data that shows that it really reduces any effectiveness.
Thank you for that. Stephen or Reid, do you want to chime in on how you have these discussions with your patients?
Well, I really agree with what we sort of already said. If you're there and you can get a vaccine, get it. Get all of them rather than try to space them out. And I love the comparison that I use all the time is children get multiple vaccinations, and as pointed out, we don't bat an eye. So I think it's a way into helping people sort of get the vaccines all at once. Once somebody's ready to go, they often will be okay with almost all of them.
So let's get into a little bit about strategies for giving multiple vaccines. We often, as you mentioned, give 3 or 4 at a time. We give many vaccines to children and use a lot of different strategies with them. In our article, we say if giving more than one vaccine, use different limbs, especially with those that may cause local reactions. So we have some that we know that, might be a little bit more likely to do that. So would you agree with that? Do you have anything else to add to that statement?
Yeah, no, I totally agree. If you can use different arms, that's great. If you can't use different arms, though, for whatever reason, it's fine to do them all in one, as long as you're separating them, by about an inch if you can. But if you can use different limbs, that's ideal. That way we can, identify a reaction more easily.
Try to inject the most painful vaccine last in a limb by itself if possible. And a couple of examples we have here are HPV and MMR. Are there other examples that you would add to this list?
Maybe tetanus. Tetanus is notoriously gives people a sore arm. So maybe if I was giving that one, I might try to inject that one last as well.
Sounds good. Another common question that we get is, could multiple vaccines be combined in one syringe?
No. No, don't do that.
We are going to put that in our article and gave an example here that it's okay to give FDA-approved combo vaccines. There are many, many out there for children to try to reduce that, vaccine burden. But just a good reminder for everyone that we shouldn't be combining vaccines. Another question that we've had several of tonight as well is, if patients are coming back for their second vaccine, how long should they wait? So if they want to space out, say, COVID and RSV, how long should they wait between vaccines?
Well, since those are two inactivated vaccines, it doesn't really matter. I mean, they could come back tomorrow if they wanted to.
Mhm.
So there's no real reason. There's no real reason for them to space it out, but if they would want to, it's totally up to them, because inactivated vaccines don't require any space between them.
Yeah, and I think that's a good point. I think there was some initial information that came out / misinformation that, folks should wait 2 weeks, because we keep getting that 2-week question. And just so the audience knows that you don't have to wait for these inactivated vaccines. But I think we want to go ahead and say if someone's getting live vaccines at a different time. So it is okay to give inactivated and live together. But what's the recommendation if they decide to separate out live vaccines?
Yeah, so then you have to wait. If you're giving a live and a live, you'll have to wait 4 weeks. So they would not be able to come back for 4 weeks to get that second live vaccine. Now, if you give a live and they want to come back for an activated, that's fine. Or if you give an inactivated and they want to come back for a live, but 2 lives has to be spaced out.
Awesome.
Sarah, can I ask you, what is the science behind that? Are we worried that if they are going to get sick, we don't want to give 2 at the same time? Or is there a science to the lack of immunity? You just need that time frame?
Yeah, it's because the 2 interfere with replication of each other. And so you don't get the antibody response that you want.
Another question that we were getting is, can we give vaccines through a tattoo?
Yes.
And
you can't give vaccines through a tattoo. You want to try to aim for the lightest part as possible. So if you have, a bunch of really dark colors, if there's a lighter color that you can put it through, that's better. But if you really don't have that option, just put it wherever. The only thing to be aware of is that your skin there is probably going to be a little bit thicker, and it might require a little bit more force to get that needle through.
In our article, we say to advise patients to expect arm soreness or pain for a couple of days after any IM vaccine. And then we often get the question about, should people use their dominant arm or their non-dominant arm, or should they rest their arm after vaccination, which I think is kind of the tendency is to not move it. So in our article, we say recommend using the arm. Is that what you tell your patients as well?
Yes. So I'm right-handed, and I will always try to get a vaccination in my right arm, because I know I'm going to use that arm more often. And I try to tell patients to do the same. They don't always take you up on that, but if their dominant arm, it's usually better because they'll move it more.
Good tip. And then in addition to applying a cool compress for pain afterwards if needed, are there any other suggestions you have pre-vaccination?
Yeah, so we don't really recommend that patients pre-vaccinate with acetaminophen or an NSAID, ibuprofen, or something like that. They do come to you and say, I already took this. Obviously, you're not going to say, well, I'm not going to vaccinate you now. Go ahead and vaccinate them. But most patients, we would suggest waiting until after the vaccination to see if they really need it. I think when COVID first came out, I think there was some questions about if we take ibuprofen, does it diminish the immune response when the COVID vaccine is working? And I don't know what the final statement on that ever was, but we try to just wait and kind of take them on a PRN basis after, if we can.
What are some tips that we can use to help patients proceed with vaccination?
Yeah, so this is a tough one, because it's hard to convince people what they feel happened, So we can point out that sometimes people can have reactions to vaccines, meaning those like flu-like symptoms, the aches and the fevers and that kind of thing. But It's not the actual flu. I usually will tell patients this isn't completely inactivated vaccine. There is no flu virus in this, so there is no possible way for this to give you the flu. But that's harder to convey sometimes than you want it to be, but just educate them as best as you can.
I'll just second that, Sarah. I think a lot of patients are pretty open to exactly that kind of little bit. There's no actual live virus in there. It can't happen. That's they, I think, find that reassuring, even if they're not totally buying it when you're saying it. But that's a great line.
Stephen, is there anything else that you say to your hesitant patients?
Yeah, I think Reid mentioned this earlier, but it's also just acknowledging the amount of mis and disinformation that's out there about vaccines, and just trying to express that you're here to answer their questions, hopefully provide insight. Doing so in a non-judgmental manner is really important to do, because I think a lot of patients, again, this is a lot of science and a lot of information that they may not be familiar with, so trying to speak to their level and trying to provide context and understanding, and just knowing that you're trying to make the best decision for their health. Sometimes that can be empowering and hopefully allow them more insight and maybe even change their minds.
What are some tips to help prevent errors when doing so?
Storing your vaccine separately, making sure you're double checking everything, making sure you have the right dose, making sure you're labeling it when it's drawn up, you're storing everything appropriately. I think those are just the best practices that we can do as pharmacists, and it starts with just staying organized. And you have some great other tips here to take only the needed doses to the area, confirm your patient, and make sure that you ask them, is this the vaccine that you're getting today? Making sure the product and the dose are correct, and then showing the patient the labeled syringe. The other thing I always kind of make sure I do before I give the vaccine is I know they've answered the questions on the intake form or whatever, the screening form, but I generally will kind of run through those with them verbally before I give the vaccine, just because I want to try to prevent as many reactions or errors as I can. So kind of going through that again is kind of my last step.
We hope you enjoyed and gained practical insights from listening into this discussion. Now that you've listened, pharmacists, physicians, and nurses can receive CE credit. Just log into your Pharmacist Letter or Prescriber Insights account and look for the title of this podcast in the list of available CE courses. You'll also be able to access and print out additional materials on this topic, like charts and other quick reference tools, from the Pharmacist Letter and Prescriber Insights websites. If you're not yet a Pharmacist Letter or Prescriber Insights subscriber, find out more about our product offerings at trchealthcare.com. Be sure to follow or subscribe, rate, and review this show in your favorite podcast app. It helps spread the word about our show and is a great way for you to let us know how we're doing. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Medication Talk.